My name is Kristen Ellard, and I'm a clinical psychologist in the program for Neuro-psychiatry and Neuromodulation based at the Martinos Center usually, but right now, no, of course. I'm going to actually just move these Zoom controls. So I'm going to be speaking about some work that I've been doing, developing neuro-rehabilitative strategies to improve treatment outcomes in bipolar disorder, also known as playing with fire without getting burned. I guess perhaps the meaning of the subtitle that I just said there, playing with fire without getting burned, can best be described by this quote from Kay Redfield Jamison. And if you're not familiar with who she is, she's a psychologist who has struggled with bipolar disorder herself throughout her adult life. She's written extensively about her own experiences and also the experiences of others struggling with bipolar disorder, with a particular curiosity about the link between mania and the artistic temperament. So she says, the fiery aspects of thought and feeling that initially compel the artistic voyage, fierce energy, high mood, and quick intelligence, a sense of the visionary and the grand, a restless and feverish temperament, commonly carry with them the capacity for madness. And the thing that's interesting about that is that literally you could take that same description and it would encompass the diagnostic criteria for bipolar disorder. So as clinicians and researchers, there's this real question that I think we need to respect of how do we treat bipolar disorder well without dousing the fire. And what you're looking at here is a picture of one of Dale Chihuly's works, and he is a famous, obviously, glass artist and also has struggled with bipolar disorder throughout his adult life, but also has created some of his most brilliant pieces of work in the context of a manic episode. Unfortunately followed by pretty paralyzing depression. But I think it's a really important question of balancing a fine line between treating a psychiatric illness and allowing someone to sort of be who they are creatively, etc. So currently, the first line treatment for bipolar disorder is pharmacotherapy. And while medications have been highly successful in stabilizing mood symptoms and preventing further episodes of mania, it does come at a bit of a cost. Patients often describe feeling blunted or numb or blasé. And most all of them will say they miss the inspiration and the motivation and sort of the fire that they experienced during episodes of elevated mood. So this got me to think about this idea of the difference between symptom reduction versus functional rehabilitation. Other areas of medicine routinely take a combined approach. And could we do the same here, essentially? So in other words, could medication be sort of like the pain relief, if you will, while maybe perhaps a behavioral intervention like cognitive behavioral therapy can be the physical therapy? And can we think of the goal of therapy in bipolar disorder not as merely reducing symptoms, but as moving a system that is functioning maladaptively towards the more adaptive state? So in the case of bipolar disorder, one logical target of rehabilitation is to increase regulatory control over affect and cognition and behavior by enhancing adaptive emotion regulation. Our capacity to generate emotions is an evolutionarily adaptive capacity that allows us to react and respond to our internal and our external environment in ways that essentially ensure our survival. However, if we misread or misinterpret these cues, they can lead us to behave in ways that are ultimately maladaptive. So this idea of emotion regulation encompasses all of the systems that enable us to use these types of cues, internal and external cues, in ways that are most appropriate to the current context or situation, which sometimes means inhibiting or modulating or even initiating these responses. In the case of bipolar disorder, from the framework of emotion regulation, the presence of internal and external affective cues tends to override all other systems, such that regulatory systems are inadequately applied. So for example, during mania, the push towards rewarding or thrilling experiences in the context of approach-related cues becomes so strong that attempts to inhibit or dial back these responses either fails or never even comes online. And during depression, internal cues to withdraw or retreat are so strong that the person becomes effectively paralyzed, amotivated, unable to take in or act on cues from the external environment. So the first question that we had in sort of thinking about this was, could we first start by capitalizing on brain plasticity by using a behavioral strategy towards shifting from maladaptive to adaptive emotion processing? And could this be a first step towards sort of a rehabilitative approach? We developed a CBT protocol that's based on the premise that emotion-related processes are evolutionarily adaptive and serve specific functions. However, these processes can become maladaptive, leading to the symptoms that you see in mood and anxiety disorders. For example, every emotion experience has a visceral autonomic component, a perceptual and sort of meaning-making component, and a behavioral response. And these three factors exist in a dynamic interacting fashion such that each component influences the other. And another evolutionarily adaptive part of the system is the pairing of emotional states with specific patterns of thoughts and behaviors, such that when I feel this way, it means this thing and I do this thing. And this provides us with sort of like a blueprint of the world. But however, this becomes maladaptive in two important ways. First, we learn to follow what our body is telling us, and we don't really question it. So if I'm feeling anxious, then there must be something to feel anxious about. Second, the pairing of certain beliefs and behaviors with certain feeling states, they're not always helpful or adaptive, or maybe they were helpful or adaptive in one context or at one point in time, but no longer are. So treatment using this approach focuses on helping to increase the person's awareness of all of these interacting components of experience, teaching cognitive or behavioral strategies that allow for new associations to develop and new ways to control the trajectory of an emotion experience that is more in line with what the current context demands. So an example of this is from a manic patient. If I'm marching into my boss's office because I want to tell them how they're doing everything wrong in their program and how I know all the right answers, am I doing this because that's the most adaptive way to approach the situation? Or am I doing this because my body's sending me a signal of urgency that it's now or never or do or die? Would I still feel like marching in there if I was in a calmer state? So really trying to help people to understand how all these processes are working. So in the initial period of this developing this research program, we did try out this treatment on a sample of 29 euthymic bipolar patients, euthymic meaning not in a manic or depressed state at the current time. And we randomized them to either continue psychopharm treatment as usual or to have 18 sessions of this CBT treatment, cognitive behavioral therapy treatment. We assessed them every 4 weeks for 6 months, assessing depression symptoms, anxiety symptoms, but then also emotion regulation skills. And through this trial, across group average, we did see significant reductions in depression symptoms, more so in the treatment group that had the CBT plus medication. Same thing for anxiety with sort of moderate effect sizes. But importantly, not everyone responded. And this is a really critical sample to look at, are people who aren't doing well. So when we look closer at the people who didn't do well with treatment, essentially we looked at the interaction of these sort of emotion regulation, emotion processing variables and treatment response. And what we find is that those patients who had a better baseline perceived of emotion control and a better baseline perception of emotion regulation strategies showed greater reduction through treatment in both anxiety and depression. And similarly, those who had greater changes in perceived emotion control and emotion regulation skills, so greater improvement in these factors, also saw greater reductions in depression and anxiety. And that, I should just preface here and say I'm going very fast, but happy to answer questions at the end. But that sort of raises the question again. So you have a set of patients who obviously are, the emotion dysregulation is a real root of their psychopathology. And there are some people that seem to be within some kind of a window of functioning that can do well with this treatment, with this behavioral treatment. And then there are others who are outside this window who can't, which begs the question, is there some sort of baseline capacity for emotion regulation that's necessary in order to have successful change via a behavioral intervention? Not necessarily needing to be functioning at the same level as a healthy person, but at least within some sort of capacity, level of capacity. So going back to this idea of symptom reduction versus functional rehabilitation, then that leads to the question, is there an intervening step that we might need to do in order for someone to benefit from treatment? So could we rehabilitate the emotion regulation related neurocircuitry using neuromodulation like transcranial magnetic stimulation? And would this approach enable us to bridge pharmacotherapy and CBT in order to improve outcomes? When we look at the data on TMS for bipolar disorder, primarily studies are targeting the dorsolateral prefrontal cortex based off of evidence from unipolar depression, so depression without mania. And the data so far is not great. You can see that there's by and large, no significant difference between active and sham treatment, or if there is an acute response, it doesn't seem to be a sustained response over time. Oops. There we go. So the next question then becomes, are we targeting the right region with neuromodulation in order to improve emotion regulation? So just to take a quick step back, when we think about neurocircuitry and emotion regulation, one sort of way to frame this idea is to think about the now fairly well-established distinct functional networks, the default mode network, the salience network, and the executive control or frontal parietal control network. If you want to be a healthy person and be able to regulate your behaviors and your thoughts and your cognitions and your arousal level in order to meet ongoing goals, that really requires flexible recruitment across these different networks at any given time. And even further, being able to sort of recruit one network and then switch to another network. So you really need to have this sort of flexible switching capacity in order to effectively regulate your experience. So we started looking at, candidate either networks or candidate regions that might be involved in the ability to switch between functional networks. And this is a paper by Golden et al. Using dynamic causal modeling to test out different models to see if one network is serving to modulate the interaction of the other two. And in this particular study, the model that shows the salience network modulating communication between the default mode network and the frontal parietal control network was the best model fit. Similar to that, another study, which was actually a few years earlier, by Sridharan et al., used Granger causality analysis, another form of effective connectivity analysis, and looking at key nodes across all three of those functional networks, and revealed a significant causal outflow from the right frontal insular cortex, which maps onto the dorsal anterior insula. And additionally, this was across an auditory task, a visual oddball attention task, and in the resting state. and further found greater in degree, which is a measure of causal outflow, also in this region of the right frontal inferior cortex. This is actually quite fascinating to me, given the fact that clinically I see patients vacillate between different mood states very closely tied to their sort of visceral experience. And the anterior insula is a region that has been implicated in sort of mapping the interoceptive experience of emotion and as a sort of an interplay to higher cortical processes. So when we go back and think about bipolar disorder again for a second and think about what is going on wrong in a regulatory sense, you can sort of think about it in terms of, I like to use this analogy of a thermostat. So a thermostat will keep you at a certain temperature. And if you go above a certain temperature, then the cooling system kicks in. And if you go below a certain temperature, then the heating system kicks in. What happens in bipolar disorder, it's like the temperature starts to rise and the cooling system never kicks in, or it starts to fall and the heating system never kicks in. So whatever that is that kicks in at that point to keep it in a relative homeostasis is not happening. And obviously in healthy adults, we all go through highs and lows, but we have some way of regulating that so that we can stay fairly, within bounds, within reason. So given all of this together, the fact that this seems to be playing a role between these functional networks, the fact that it also is mapping onto these visceral states, it seemed like a very interesting region to look at and to understand as potentially dysfunctional in bipolar disorder. So we did a resting state fMRI study looking at the connectivity between the dorsal anterior insula and key nodes, again, of these three networks: default mode network, salience network, and frontoparietal executive control network, and compared bipolar patients with unipolar patients and healthy controls to see if there was anything that was deviating in the way that the anterior insula was connected to these networks. And what we found is the functional connectivity between the right dorsal anterior insula and the right ventrolateral prefrontal cortex differentiated bipolar patients from healthies. And in addition, the functional connectivity between the right dorsal anterior insula and the left inferior parietal lobule, or IPL, differentiated bipolar patients from both healthies and unipolar patients. So here's some just graphs of the connectivity. So you can see for the right anterior insula, right VLPFC, bipolar patients had significantly weaker functional connectivity than healthy controls. It was also weaker than unipolar, but that was not significant after corrections. And here you can see the right anterior insula to left IPL functional connectivity was significantly weaker for bipolar patients relative to both unipolar and healthies. And with one caveat, I recognize that interpretation of anticorrelations is a controversial topic, but nonetheless, we can agree that it was weaker in the bipolar depressed than the healthies or the unipolar. Further, this connectivity pattern, right dorsal anterior insula, left IPL, also was a significant classifier of bipolar relative to unipolar patients with an 87% negative predictive value. So taking this in mind, we went back to the data from the patients who did the CB treatment trial and looked at their resting state data to try and see if there was any relationship between these connectivity deviations that we found and some of these indicators of treatment response. And what we found is that this same functional connectivity pattern of the right anterior insula to left IPL significantly correlated with baseline perceived emotion control. And I should say this particular measure, higher values means more pathology. So this result is showing stronger functional connectivity between anterior insula and left IPL is related to better perceived emotion control at baseline. We also found that the functional connectivity pattern between the right anterior insula and the right VLPFC at baseline predicts the amount of change in emotion regulation skills across treatment with CBT treatment, such that stronger connectivity relates to greater improvement in emotion regulation skills and perceived control. So coming back to our model again, so then the question was, okay, could we rehabilitate emotion regulation related neurocircuitry using neuromodulation to the VLPFC or the IPL? And why not the anterior insula? The anterior insula is very, very difficult to target using non-invasive neuromodulation. So we wanted to look at it from a circuit-based approach if we can engage anterior insula using these two cortical targets. And here again, could this approach bridge pharmacotherapy and CBT to improve treatment outcomes in bipolar disorder? So that's where we are today. I'm almost done, 30 seconds. We're running a pilot study right now, just trying to see if we can, proof of concept, use TMS for target engagement to improve emotion regulation performance through excitatory TMS stimulation of the VLPFC or the IPL. And we also want to find out if stimulation of the IPL is as effective as stimulation of the VLPFC, given the fact that the VLPFC target is in an area that is very close to the facial muscles. It's very uncomfortable to receive TMS here as opposed to here. So we're randomizing 15 patients to receive 600 pulses of intermittent theta burst TMS to VLPFC, IPL, and a sham location in the dorsal medial prefrontal cortex in a randomized crossover design, so everybody gets TMS to each of those target sites across 3 days. This is one of the tasks that we're using just quickly. It is a task that asks you to ignore the effective image, the salient image in the background, and select which number is the distractor number, with some trials being easy because it's in the same position as your finger, and other trials being hard because you want to press 1, but the correct answer is 2. So it effectively is probing the ability to regulate your response to salient information while staying on task with goal-directed activities, while also inhibiting prepotent responses. And this is our very, very preliminary data for our first 9 patients. And this is pre versus post for the most challenging trials, the negative interference trials. And so far, we're seeing significantly faster reaction time following IPL stimulation relative to sham, and also following VLPFC stimulation, relative to sham, and no significant difference between the 2 target locations. Which again is still good news, because if we can show that the IPL is as effective as VLPFC, we may be able to move to a more feasible target location with greater tolerability. And our next steps then, after we do the pilot trial, we're going to establish dose effects as part of my K23. We're also testing the effects of individualized target identification through resting state fMRI. From there, we hope to test it as a standalone treatment, and then ultimately test out this rehabilitative model by seeing the effects of this adjunctive TMS protocol on CBT outcomes. And that is all. Thank you very much.